Welcome. Today, we're diving into the complexities of autoimmune optic neuropathy, a challenging condition that can significantly impact vision. We'll explore its causes, how it affects the eye diagnosis, treatment, and what the future holds for those affected. Autoimmune optic neuropathy, as the name suggests, is triggered by the body's own immune system mistakenly attacking the optic nerve. The exact reasons why this happens are often unclear, but several factors are thought to play a role. It can occur as a primary autoimmune disorder, where the immune system targets the optic nerve directly without any other underlying systemic disease. Alternatively, it can be secondary to other systemic autoimmune diseases such as lupus, rheumatoid arthritis, sarcoidosis, or vasculitis. In these cases, the optic nerve damage is a consequence of the broader autoimmune response. Genetic predisposition and environmental triggers might also contribute to the development of this condition, although specific genes and triggers remain largely unidentified. Let's delve into the pathophysiology. In autoimmune optic neuropathy, the immune system mistakenly identifies the optic nerve as a foreign invader. This misidentification leads to an inflammatory response, involving the activation of immune cells and the release of inflammatory molecules such as cytokines and antibodies. These inflammatory mediators damage the myelin sheath, the protective covering around nerve fibers, and the nerve fibers themselves. This damage disrupts the transmission of visual signals from the retina to the brain, leading to vision loss. The specific mechanisms involved can vary, but often include antibody-mediated cytotoxicity, where antibodies directly attack the optic nerve cells, and cell-mediated immunity, where T cells launch an assault on the nerve tissue. This ongoing inflammation and damage can cause irreversible optic nerve damage if left untreated. The exact epidemiology of autoimmune optic neuropathy is difficult to determine because it is a relatively rare condition and often underdiagnosed or misdiagnosed as other optic nerve disorders. It's estimated to account for a small percentage of all cases of optic neuritis. It tends to affect adults, typically between the ages of 20 and 50, but can occur at any age. There may be a slightly higher prevalence in women, which is common in many autoimmune diseases. Due to its association with other systemic autoimmune disorders, the prevalence may be higher in individuals already diagnosed with conditions like lupus or rheumatoid arthritis. Accurate epidemiological data is needed to better understand the true incidence and prevalence of this condition. The signs and symptoms of autoimmune optic neuropathy can vary from person to person. The most common symptom is gradual or sudden vision loss in one or both eyes. This vision loss can range from mild blurring to severe visual impairment. Other common symptoms include eye pain, particularly with eye movement, color vision changes such as difficulty distinguishing between colors, and visual field defects, which may present as blind spots or tunnel vision. Some individuals may also experience photopsias, which are flashes of light. The symptoms can develop rapidly, over days or weeks, or more gradually over months. Because these symptoms can overlap with other optic nerve disorders, it's essential to seek prompt medical attention for accurate diagnosis. Diagnosing autoimmune optic neuropathy can be challenging as there is no single definitive test. The diagnostic process typically involves a comprehensive eye examination, including visual acuity testing, color vision testing, visual field testing, and a dilated fundus examination to assess the optic nerve. Neuroimaging studies, such as MRI of the brain and orbits with gadolinium contrast, are crucial to rule out other conditions, such as optic nerve tumors or demyelinating diseases like multiple sclerosis. Blood tests are performed to look for autoantibodies and markers of inflammation, such as erythrocyte sedimentation rate, EESR, and C-reactive proteins RP. In some cases, lumbar puncture to analyze cerebrospinal fluid may be necessary to rule out infectious or inflammatory causes. A diagnosis of autoimmune optic neuropathy is often made based on a combination of clinical findings, neuroimaging results, and exclusion of other possible causes. The response to immunosuppressive therapy can also be used as a diagnostic criterion. While autoimmune optic neuropathy doesn't have strictly defined subtypes like some other diseases, it can be broadly categorized based on whether it occurs as a primary autoimmune condition or secondary to another systemic autoimmune disease. In primary cases, the optic nerve is the main or only target of the immune attack. In secondary cases, the optic nerve involvement is part of a broader systemic autoimmune process. Understanding whether the condition is primary or secondary is important for guiding treatment strategies and managing associated systemic conditions. The primary goal of treatment is to suppress the immune system and reduce inflammation to prevent further optic nerve damage. High-dose corticosteroids, such as intravenous methylprednisolone, are often the first-line treatment to quickly reduce inflammation. After the initial course of corticosteroids, long-term immunosuppressive medications, such as azathioprine, mycophenolate mofetil, or methotrexate, are typically prescribed to maintain disease control and prevent relapses. In severe cases or when patients don't respond to other treatments, intravenous immunoglobulins (IVIG) or plasmapheresis may be considered. Regular monitoring by an ophthalmologist and a rheumatologist is crucial to assess treatment response and manage potential side effects of medications. Visual rehabilitation, including low vision aids and strategies, can help patients adapt to vision loss. Unfortunately, there are no specific measures to completely prevent autoimmune optic neuropathy, as the underlying causes are not fully understood. However, individuals with known systemic autoimmune diseases should work closely with their healthcare providers to manage their underlying condition effectively. Early diagnosis and prompt treatment of systemic autoimmune disorders may potentially reduce the risk of optic nerve involvement. Maintaining a healthy lifestyle, including a balanced diet, regular exercise, and avoiding smoking, may also support overall immune health. Regular eye examinations can help detect any early signs of optic nerve damage and allow for timely intervention. The prognosis for autoimmune optic neuropathy varies depending on the severity of the condition, the timing of diagnosis, and the response to treatment. Early diagnosis and prompt initiation of immunosuppressive therapy are associated with better visual outcomes. Some individuals may experience significant improvement in vision with treatment, while others may have persistent visual deficits. Relapses are common, highlighting the need for long-term monitoring and maintenance therapy. Recent research is focused on identifying specific autoantibodies and immune mechanisms involved in autoimmune optic neuropathy to develop more targeted therapies. Clinical trials are investigating the use of novel immunosuppressive agents and biologic therapies to improve treatment outcomes and reduce side effects. Future research holds promise for developing personalized treatment strategies based on individual patient characteristics and immune profiles.